All right, let's jump right in. Today, we're tackling a really critical topic in medicine, how we actually identify fungal diseases. We're going to break down the key diagnostic markers, basically the essential tools clinicians use to unmask these tricky and often very elusive infections.
So think about it. How do you diagnose an enemy you can't even see? Fungal infections are notoriously difficult to pin down. They can mimic a whole bunch of other diseases. And honestly, by the time the signs are really obvious, it can be dangerously late, especially for our most vulnerable patients. So the big question is, how do we find the clues? How do you track down something that's microscopic and hiding deep inside the body? Well, that is exactly the puzzle we're going to piece together today.
Okay, so this is our guide. This diagnostic table you see here is basically our roadmap for this entire explainer. We're going to walk through it marker by marker so we can really understand what each one tells us, when we should be using it, and, just as important, what its limitations are. Let's get started. We're going to start with the most direct approach, antigen markers. The whole idea here is that these tests are designed to detect a specific piece of the fungus itself, like a protein or a sugar from its cell wall. The best way to think about it? It's like finding the culprit's fingerprint right at the crime scene. It's direct evidence. First on our list is galactomannan, or GM for short. Now, this one is a huge deal for aspergillus, which is the fungus that causes invasive aspergillosis. It's incredibly useful because it lets you get an early diagnosis from a blood sample or from fluid collected from the lungs. And here's a really interesting part. Higher levels of GM often mean a greater fungal burden. So it's not just a simple yes or no test. It actually helps clinicians gauge how severe the infection might be.
Next, we have 1,3-beta-D-glucan, which everyone just calls BDG. So if galactomannan was a specific fingerprint, think of BDG as casting a really wide net. It's a component found in the cell walls of a ton of different fungi, which makes it a fantastic pan-fungal marker. A positive BDG test is a major red flag that a fungal infection is likely, flagging things like Candida, Pneumocystis, and Fusarium, just to name a few.
But, and this is a huge but, you absolutely have to remember, while that net is wide, it has two major holes. BDG will not detect Cryptococcus or the zygomycetes. Let me say that again because it's that important. It does not detect Cryptococcus or zygomycetes. So a negative BDG test does not rule out those infections. You've got to order a different, more specific test if you still suspect one of those is the culprit. And speaking of Cryptococcus, well, it has its own highly specific test, the cryptococcal antigen, or CRAG test. This is your absolute go-to for diagnosing infections from Cryptococcus neoformans. And that's a big deal because this fungus is notorious for causing a very serious form of meningitis, especially in immunocompromised patients. We can detect this antigen in either cerebral spinal fluid or in the blood. And this quote really says it all about the power of this test. It's highly sensitive and specific. In the world of diagnostics, that's the gold standard. Sensitive means it's great at finding the disease if it's there. Specific means it's great at correctly saying the disease is not there if it's absent. This really cuts down on false positives and false negatives, making it an incredibly reliable tool when the stakes are as high as they are with meningitis. Now, for diagnosing infections caused by Candida, we've got a two-part strategy, mannan and anti-mannan. Mannan is the antigen, that's a piece of the fungus itself. Anti-mannan is the antibody, that's our body's response to the fungus. So why look for both? Well, by searching for the invader and our body's reaction at the same time, we seriously improve the diagnostic sensitivity of the test. Okay, let's shift our focus a little. So far, we've been looking for the fungus directly. Now, we're going to look for the indirect evidence, the clues it leaves behind. We're talking about either the body's immune response, which we see as antibodies, or the chemical waste products, called metabolites, that the fungus produces. Antibody tests, which look for IgM and IgG, are really useful for diagnosing what we call the endemic fungi, so things like histoplasma, coccidioides, and blastomyces. These infections tend to be a bit more subacute or chronic, which actually gives the body enough time to mount a detectable antibody response that we can then measure. But here's the catch, and it's a big one. To make antibodies, you need a functioning immune system, and that's precisely why these tests have limited use in immunocompromised patients. Their bodies might just not be able to produce enough antibodies to be detected even when they have a serious infection. This can lead to a false negative result, which is why those antigen or molecular tests are often the better choice for this group of patients. It's a critical limitation to keep in mind. Moving on to metabolites, we've got D-arabinitol. This is a sugar alcohol that's produced by Candida species. So finding elevated levels of it in a patient's urine or serum can be a pretty good indicator of invasive candidiasis. It's like finding the invader's chemical signature. For our final section, we're going to look at some of the more advanced techniques. This includes molecular tests that look for fungal DNA and enzyme markers that can signal tissue damage that's associated with certain infections. So what exactly is a molecular marker? Well, if an antigen test is like finding a fingerprint, then a molecular test is like recovering the suspect's entire DNA profile. It's designed to find the unique genetic code of the fungus, which makes it an incredibly precise approach. And the most common molecular test out there is PCR, or polymerase chain reaction. As you can see, this can be used on all sorts of samples: blood, lung fluid, tissue. Its biggest advantage is its high sensitivity. It can detect even the tiniest amounts of fungal DNA from a whole range of pathogens, like Aspergillus, Candida, and Pneumocystis. Next, let's talk about an enzyme marker, lactate dehydrogenase, or LDH. Now, LDH is an enzyme that's normally found inside our cells. But when cells in the lungs get damaged by the fungus Pneumocystis jirovecii, they release LDH into the bloodstream. So finding elevated LDH in a patient's blood is a classic clue that might point towards PJP. But as we're about to see, it's not the whole story. So here's the crucial point about LDH. It's kind of a double-edged sword. Yes, it is an important clue when you suspect pneumocystis pneumonia, but it is very nonspecific. Lots of other conditions can cause high LDH levels, and that means it has to be used in combination with other clinical signs and other markers to make a reliable diagnosis. You can't just use it on its own. Okay, we have covered a lot of ground. So now, let's put it all together. How does a clinician decide which test to use? Well, it all comes down to the suspected disease and the patient's specific clinical situation. This slide is a great little summary, kind of like a cheat sheet. If you suspect invasive aspergillosis, your first thought should probably be the galactomannan assay. For a patient showing signs of meningitis, the cryptococcal antigen test is your go-to because it's so specific. And if you just need a broad initial screen for a fungal infection, BDG is a fantastic place to start. Just remember to keep those two big exceptions, Cryptococcus and Zygomycetes, in the back of your mind. So let's end with a question to get you thinking. A neutropenic patient, meaning they have a weakened immune system, has a fever and nodules in their lungs. Looking back at all our markers, what test would you order first? What's going to give you the most valuable information early on? The answer lies in choosing the marker with the best shot at an early diagnosis for the most likely bug in this scenario. And it's by applying this knowledge that these markers become truly powerful clinical tools.